A very good evening to one and all present over here. We are yet and continuing with another class of NEET MDS Endodontic MCQ discussion. This is actually the part two, which actually include mainly the amalgam, gold restorations, cast metal restorations, composites, etc. So hope you had a very nice day. So let us start the discussion. On the initial section, we'll be discussing with dental amalgam. Coming with the most easiest question. In amalgam alloy, which of the following act as an oxygen scavenger? Most of the people know this answer without seeing the options even. But the options are copper, zinc, palladium, and silver. The answer is actually zinc. Why? That is mainly because the zinc react with the oxygen that is present and it forms zinc oxide. So what happens is like they actually reduce the oxidation of the metal, thereby they minimize the corrosion of the particular metal and they improve the overall durability and longevity of the amalgam restoration. So that is the first answer to this question. So zinc is the main person or the main metal that is responsible for the reduction of oxidation of the particular metal, thus preventing the corrosion. Next question. Which of the following phases of dental amalgam has minimum strength? So we have already heard that minimum strength is always seen with gamma 2 phase. Why? Let us see the reactions that is involved. So coming to the conventional amalgam, in early days, the amalgam was having low copper. The low copper amalgam, what happens is like the copper silver combination, you can see the first reaction, gamma. Gamma is actually Ag plus Sn. So they have no copper. It is the combination of actually silver and tin. So they react to form gamma 1 and gamma 2. Gamma 2 is a silver a mercury combination, that is gamma 1, and tin mercury combination, that is gamma 2. The gamma 1 from here there are some important points that you have to keep in mind. Gamma is of course the strongest phase. Gamma 1 is actually having a body centered phase and gamma 2 is having a hexagonal phase. So here, if somebody asks which is the strongest phase, it is always a gamma phase. Which is the least stable phase, it is gamma 2 phase. Next important thing that you have to know from this area is about the hardness. The hardness is again the strongest phase, gamma phase. Second, going to gamma 1 phase, and the least hardest phase or stable phase is gamma 2 phase. And gamma 2 phase is actually the same phase having the poor corrosion resistance. So hope you understood this. The conventional amalgam had a copper content very low, that is below 6 percentage. So and because of that, there was large amount of gamma 2 phase formed. So in the upcoming newer amalgam, that is a high copper amalgam, we should actually reduce the gamma 2 phase in order to reduce this weakest phase. So what happened is like we came to this uh, high copper amalgam where there was large amount of copper. You can see in the first image as such. Again, gamma react to form gamma 1 and gamma 2. What happens is that this gamma 2 react again with the combination of silver and copper. Okay, they again form eta phase and also gamma 1 phase. Now, what happened in high copper? You can see the final reaction. There is no gamma 2 that is being formed. So that because of this reason, high copper amalgam is actually showing more corrosion resistant property when compared to the low copper amalgam. So simply remember, low copper, there is low amount of copper, less than 6 percentage. So there is large amount of gamma 2 phase, making that least stable amalgam. But in the case of high copper amalgam, what happens is like even though gamma 2 is formed, that gamma 2 again react with the existing copper to form eta phase, making the elimination of gamma 2, making that stronger. Next question. Which of the following, which is not true about high copper amalgam alloy? Now we know that high copper amalgam is having less of a gamma 2 phase, so it is more stable. It is having more resistance to corrosion, and the amount of mercury to alloy ratio is less, And low creep. Creep means time dependent plastic deformity. So it is having good advantage. See the first option A, low tensile and compressive strength. B, low mercury alloy ratio. C, high tensile strength, low creep. So we know that when compared to the low copper amalgam, high copper amalgam is having good properties. So the answer which is not true is like A, that is, it is not having low tensile or low compressive strength. All the two portion is very high and having good properties compared to the low copper amalgam alloy. Next question, setting time of amalgam is best controlled by. So it is all, see the options using the spherical particle, lathe cut alloy, altering the mercury alloy ratio or trituration. We know that mixing of a material always best control the setting time, but like the setting time is also altered by the particle size, what is the mercury and alloy ratio. But this the question is particularly being asked, setting time of amalgam is best controlled by. So the answer is like trituration time, how much time we triturate, because if it is under triturated, it will be having a soupy mix. I mean, if it is having large amount of mercury, it will be having a soupy mixture. And if it is having a low amalgam or low mercury content, it will having a sandy appearance. So, and also the type of trituration depends the setting time of amalgam. So both the trituration time and speed actually control the setting time. What happens? Increased trituration time and speed shortens the working and setting time of amalgam. This point you have to keep in mind. What happens is like increase the trituration time and speed means inversely proportional. It actually shortens the working and setting time of amalgam. Next question. Absorption of mercury in the human body occur least from. So it is lungs, gastrointestinal tract. This was one of the questions that was asked for actually the All India AIM question paper. So this is actually an important portion, especially the mercury toxicity, various levels, various concentrations, various maximum threshold limit, etc. has to be kept in mind. Actually, the question has been asked from those areas. So absorption of mercury occurs least from which area? Is it lungs, GIT, skin or kidney? The answer is actually kidney. So from kidney, the absorption is actually very less. Next question, very important question. The threshold limit value of mercury exposure is, it is 0.05 mg per cube of M. So just mug it up. That is the only thing you can do. Think that it is actually 5 by 100. That is 0.05 percentage. I mean 0.05 mg per M3 is the threshold value of mercury or the limit value of mercury exposure. Who was associated with second amalgam war? See, Ames question again. So we know that there have been three amalgam wars that have taken place. First amalgam war, second and third amalgam wars, based on the various controversies whether to use amalgam or not. So I think most of the people is not aware with the people who are associated with this. So before answering this, I would like to give a small description about the amalgam wars. First amalgam war was conducted by the American Society of Dental Surgeons in the year of 1843. Because all the filling materials, like it was a conflict between amalgam and also gold, and they were thinking like gold is more superior when compared to the toxic effects of actually amalgam. And the second amalgam war was in 1920s, and it was by a German dentist, Alfred Stock, that actually started the second war. And he actually claimed that the mercury had large amount of problems and also serious health problems related to the second amalgam war. Third amalgam war was by Dr. Huggins. And again, controversies like mercury causes various health problems that affected the cardiovascular system, central nervous system, etc. And he also stated that the patient recovered from diseases like multiple sclerosis once they started removing the dental amalgam fillings. So this is actually the three amalgam wars, first, second and third. So to know, the first amalgam war was done by the American Society of Dental Surgeons. Second amalgam war was by the Alfred Stock. He's a German dentist. And third is like Dr. Huggins. So the question is like who was associated with second amalgam war? So Alfred Stock is a person for second amalgam war. Huggins C is actually the person responsible for the third amalgam war. What is the amount of fluoride in amalgam? So it is 1% of stannous fluoride that is present. So what is the advantage of adding fluoride to amalgam? We know that fluoride often have the potential to remineralize and also anti-carcinogenic property. And they actually prevent the secondary caries formation beneath the restoration. That is one of the most important problem with amalgam and composites, etc. So in amalgam, they actually prevent again the secondary caries formation. But the main disadvantage with adding fluoride to the dental amalgam is like the amalgam, the fluoride actually causes less compressive strength. It makes the dental amalgam of a less compressive strength and also the ductility. So that is the main problem when we add fluoride to amalgam. Next question. The pins that causes minimum stress in dentin. We know that there are various type of pins like threaded pin, cemented pin, friction lock pin, etc. So what do you mean by cemented pin? Cemented pin means the slot will be larger. We'll be just using a loosed pin and it will be actually attached with the help of a cementer. So there is no stress developed on the dentine or the enamel which we place. While the case of threaded amalgam pins and also friction lock pins, they have been threaded or actually screwed onto the smaller slots where the screws are larger. So large amount of stress is generated on the dentine. So the minimum stress is actually caused by the cemental pin. That is because the slot is larger and inside that we place the pin and it is actually attached by a cement. So minimum stress is by cemented pin. Some of the important points that you have to memorize in this portion, which is having retention, maximum retention. Maximum retention is by self-threading pins because it has been threaded onto the dentine followed by the friction lock pins and at last the cemented pin. So which had minimum stress is like cemented pin. Pulpal stress, again, which have more of a pulpal stress is like self-threading pills. Same scenarios, same portion has been actually seen as that of retention, which causes the pulpal stress also, right? Next, another we know there is a newer system that is threadmate system, which is the commonly used self-threading pins. So self-threading pins have lot amount of actually various companies, and the most important self-threading pins that we use is actually the threadmate system. Another important thing that we have to memorize is the relative position of pin from DEJ in pin rated amalgam must be 0.5 to 1 mm. That is very important. So what is the distance between the like pin if we place at actually the dentino enamel junction? It is actually 0.5 to 1 that you have to keep in mind. Next is the most retentive pin type of pin that we have already discussed. The most retentive type of pin is actually the self-threaded pin, that is followed by the friction lock pin and also the cemented pin. The color code for the regular size pin in the thread-mate system pin system is. So I told that in the self-threaded, the most common system of pin is actually threaded mate system. So they have lot of colors and based on actually its size. Think like it is gold, silver, like which we use, thing like that. The gold we use, the silver then we use, then red and pink. So it is actually regular, minim, minikin, minuta. So that is it is actually kind of a rhyming word. So memorize like that. Regular, minim, minikin and minuta. So regular is like gold color, silver, red and also pink color. So as you can see, the regular is having of a larger size actually. As it comes downwards, it is of lower size. So the color code of a regular pin. So now we know it is gold, the first one, regular. Don't forget the name. Remember it as like that rhyming words, regular, minim, minikin and minuta, right? Next question. Angle at gingival bevel in a class 2 inlay cavity. So we know that we used to give inlay cavities angulation, right? So what is the angle for a gingival bevel in class 2 inlay cavity? So it is 30 degree. So I would like you to memorize this particular slide to answer most of the question from cast inlays and amalgam restoration. So the comparison help you to actually memorize what is the difference. Understood? See, cast inlay. So we know that we used to actually use cast inlay in a very large and extensive cavity, but amalgam in a very conservative cavity. And cast inlay is used in, not used in young patients because the cavity preparation is very large. So young patients, the pulp horn is very superiorly placed. So there is chance of exposure when we actually do the cavity preparation. So in cast inlay, it has been contraindicated in the young patients. While the case of amalgam restoration, it is indicated in young and old patients. So of course, cast inlays are actually cost more. That is because it is an indirect technique where we'll be doing impressions, taking to lab, etc. It is amalgam is of course less cost. Now the burrs, very important. We know that 245 bar is used for amalgam, right? But 27 bar, 1 bar is used for cast inlays. Now we know that in amalgam we give an occlusal convergence. That is the thing that is responsible for the retention of the amalgam in the cavity. But in the case of a cast inlay, we know that the walls are divergent occlusally. It is like this. It is divergent occlusally. So what is the angulation? That is a very important question. Taper of 2 to 5 degree to each wall, not totally 2 to 5. That is another important question that you have to keep in mind. 2 to 5 degree divergence is given per wall. In a single wall, 2 to 5. The next wall also 2 to 5. Hope you understood. We know that in amalgam restoration, we don't give much of a bevel. But there is only one bevel that I've already discussed in the last class. It is the gingival bevel. We can give it with the GMT, etc. So gingival bevel is present in amalgam, but it is not actually indicated like occlusal bevel. The other bevels which are seen in cast inlays is not seen in amalgam. But in cast inlay, there is occlusal bevel of 30 to 40 degree. Please keep in mind 30 to 40 degree. Gingival bevel, as I told, it is seen in amalgam. It is 50 to 20. While the case of the inlays, it is 30. That is twice that of the gingival bevel that is seen in amalgam. Right. The proximal box of amalgam is in an inverted truncate shape. But here the proximal box is like a box shape. Right. Now we know that the cavo surface angle of amalgam is 90 degrees. That is called as a butt joint. But lap joint or slip joint, when the ankle, I have already discussed in the last section, if it is more than 90 degree, it is called as lap joint or slip joint. So here the cavo surface angle is 130 to 140 degree. That is to the tooth structure. The remaining, the metal comes, right? The metal is the remaining of 180. 130 minus 180, it is like 40. So it comes, that is the calculation actually. Okay. Marginal metal angle of amalgam because 90 is a cavo surface angle means metal will be of 90 degree. Flares are not indicated in amalgam, we know, but flares are seen in cast inlays. It is on the facial and lingual proximal walls. Okay. Now we know that the distance of a cavity is 1/4 of an intercuspal distance in amalgam restoration, and in the case of a cast inlay restoration is 1/3 of an intercuspal distance. So this two important, like you need not actually study the entire thing. Just keep this slides in your mind and do the proper comparison between amalgam and cast inlays, especially the cavo surface angle, the burr which is used, what is the angulation of the axial walls, etc. You have to keep in mind. Next question. The difference between a class 2 amalgam and cast restoration is, we have already studied, it is actually the bevels. We know that in cast restoration, there is more of a bevel when compared to that of a class 2 amalgam. So talking about bevel, as I told, gingival bevel is 15 to 20. It is twice in the case of a cast restoration, that is 30 to 40. In composite, it is 30 degree. A very important thing I've already discussed in the last class, beveling is not indicated in a margin situated in root surfaces. Please keep in mind. Next question. In a class 2 amalgam restoration, beveling on the gingival margin when gingival margins are on root surface. As I told, root surface, no bevel. So the answer is no bevel. The type of stress to which dental amalgam is most resistant. We know that there are a lot of stresses: shear stress, tensile stress, compressive stress, impact stress. To which stress the dental amalgam is resistant, it actually resists that stress. That is compressive stress. It actually is able to resist the compression, that is because of the bulk of the material and also the strength of the material once it actually gets sets. Amalgam have high compressive strength and low tensile strength. Compressive strength of amalgam should be a minimum of 310 NPa. So please keep this important point in your mind. Next question. An average half-life for the transport of mercury through the body to the point of excretion is. So we know that through various part, the amalgam has been excreted like the kidney, skin, lungs, GIT. But as I told, it is very much less in the kidney absorption. And so what they are asking, what is the half-life for the transportation of this mercury to the point of excretion? It is actually 55 days. That again, you have to keep in mind as such. Some important point that I've added to this so that it has been commonly been asked in certain competitive exams. First question. The methyl mercury is the most toxic form and is absorbed 90 to 95 percentage from the gut. So please keep in mind, methyl mercury is actually the most absorbent product of the amalgam. The maximum level of occupational exposure that is considered safe is 50 of mercury per mmHg per millimeter cube. So maximum level is like 50, right? And the mercury is volatile at room temperature and have a vapor pressure of 20 mg per millimeter cube. So please keep this in mind. Okay. And next thing is like about 65 to 85 percentage of the inhaled mercury vapor is retained within the body. That numbers that you have to keep in mind. Occupational exposure is 50. The pressure is like 20. And about 65 to 85 percentage of the mercury vapor is being absorbed by the body. As we have discussed the last question, half-life of mercury is like 55 days, and 15 mmHg mercury should be actually is the acceptable normal level in urine and 4 in blood. Please keep in mind, in blood it is 4, urine it is 50, right? Again, we know that amalgam, there is large amount of corrosion products that is seen. Why I added this slide is like a certain question has been actually added, which is the corrosion product that is formed in the low copper alloy. We have already discussed like we have a weakest phase in a low copper alloy, that is gamma 2 phase. We know that it is SN8Hg, that is tin, which is responsible for making the amalgam weakest. So what happens is like the tin acts or react to the oxygen and the chloride to form tin oxychloride. That is responsible for the corrosion of the low copper alloy. So the corrosion product are SNO and SNOCl. So what happens is like this is actually responsible for the macroscopic or primary expansion. The secondary expansion, we know that it is the delayed expansion. That is because zinc containing mercury react with water to form zinc, hydrogen, zinc hydroxide and also hydrogen. Because of the hydrogen pressure, it causes like the expansion. So please keep in mind, low copper, we know the tin is actually the culprit. So tin oxychloride is actually the most common a corrosion product that is found. Talking about high copper, we know there is no gamma 2 phase. It got eliminated and they formed a new phase that is actually the eta phase, which is of less corrosion resistant and making the amalgam stronger. But still, certain corrosion products are formed in high copper. So please don't get confused. In low copper, it is tin oxychloride. Here it is SNO, that is tin oxychloride, and also copper oxide, mainly copper oxide. Okay. Tin oxychloride was mostly seen in low copper alloy, and the corrosion products like SNO and SNOCl is actually, along with that, copper oxide is mainly seen in high copper and mixed alloy. So we know that chemical corrosions is there, electrochemical corrosions is there. In chemical corrosions, mainly silver sulfide is being formed. In electrochemical, we know that galvanic crevice and also stress corrosions are there. Next question. The most conservative tooth preparation for amalgam is prepared with. It is always a 330 bar that actually, even though we uses a 245 bar, the most conservative preparation is actually with the 330 bar. Now coming to some of the important questions from gold. Ammonia treated gold foil is known as. It is actually non-cohesive foil. If there was no adulterant or no impurities like ammonia, there might be actually adhesion of the gold taking place. That is called as a cohesive gold. Non-cohesive gold means there is no adhesion of the amalgam. We have to remove, gold. We have to remove the surface adulterants like ammonia, and then only we can actually make that gold cohesive. So these are actually the non-cohesive gold. Now, KO surface prepared with margins for direct filling gold. We have already studied about the various KO surfaces of cast metal, amalgam, etc. So it is 30 to 40 bevel that is given in the gold, direct filling gold. Please keep in mind. Gold with the highest strength and can be used in stress bearing area. It is electrolyte. Electrolyte is actually a combination of calcium, that is 0.1 percentage of calcium, to that of gold. So what happens is like this calcium is being actually made by dispersion strengthening method, which makes the gold alloy more stronger. So the gold that can be used in high strength areas, so stress bearing areas like our molar, it is electrolyte. So some other important points that you have to keep in mind is like, which is actually another being used as the core and finishing method. It is actually the electrolyte again. For veneering and veneering, we use the matte foil. For the external surface veneering, we use the gold foil. And bulk filler, it is the matte gold. Please keep this in mind. Next, some questions from composites. As compared to UV light, visible light can cure. So one of the advantage of visible light is like it can cure a greater depth of resins when compared to that of the UV light. The depth of penetration is more. So I would like to discuss some important points recently and always ask questions, the activator initiator system. We know that there is a chemically activated system. We know that there are two paste A and also paste B is there. And paste A contain benzoyl peroxide initiator. Paste B contain, it is the tertiary amines. So I have made a code like A, B, C. The C is actually the chemically activated. A means amines, B means benzyl peroxide. At least you can actually memorize the some of the activators that is actually seen. C is actually the chemically activated. B means it is actually the benzyl peroxide, and A means the amines, that is C. Now, visible light have camphor quinones as an initiator, and activator is actually diketon. It is also an amine. And this is actually the most popular composite that is used. The visible light is used in here. And again, ask question, what is the wavelength of the light that we use? The wavelength of light that we use is actually of a blue wave spectrum, which ranges from 400 to 500 nanometer. And what is a correct nanometer means? It is 474 nanometer. So please keep this in mind. It is very important. And in that, camphor quinone is actually the photoinitiator, because photoinitiators have the capacity, especially camphor quinones, absorb the photons from the light which we give at 475 nanometer, that is the blue region. Another important thing is like we know that various health hazards is virtually been actually eliminated because of the visible light cure. I am discussing this point that is because the question might be like which among the following is not true or not false, etc. And what is a requirement? Require a minimum of 20 seconds for the adequate curing. While in the case of UV light, it was 60 seconds. Here, visible light, it is just 20 seconds, and we have to keep a distance of about 2 mm for actually the composite curing from the tip, and it can cure at a depth of 2 mm. That is why we do an incremental curing. As I told, like this was the comparison that I've already given. UV light cause large amount of retinal damage, while in the case of visible light, there was no injury to the eye, and depth of cure in the case of UV light was 1.5 mm. So why I'm discussing is like which of the following is not true. This will be the question. So you need to know each and every point to give the answer. And depth of curing for UV lights were actually 1.5 mm, while in the case of visible light, which we commonly use is like 2 mm. Okay. What is the advantage of light cure over self cure? It is having an extended working time, reduced porosity, better wear and abrasion resistance. That is why the light cure composites are more good when compared to that of the self cure. It is having a time for the working to take place, right? Next question is in class 3 composite preparation, the retention point should be placed in. So we know that we used to do our composite restoration, class 3 composite restoration. So in certain cases, we have to give a retentive points where we'll give in the axial wall, entirely in the dentine, at the dentino enamel junction, at the expense of facial and lingual wall. It is actually entirely in the dentine. We have to place a retentive points entirely in the dentine. So the retentive grooves or coves for a class 3 composites are placed always along the gingivo-axial wall. That is the gingival wall and the axial wall, the line angle we actually give. Sometimes it might be in the inciso-axial line angle. It is at that 0.5 mm depth into dentine. They are never placed on the facio-axial and lingual axial because there is chance of fracture. That is why we are not providing this grooves and coves or the retentive features on actually the facial and the lingual side. Next question. Which laser can be used to cure composite resins? We know that nowadays laser have been actually used for curing composite resin. The answer is argon. Argon laser is actually used for curing composite. So we know that there are a lot of different curing systems of composites like our LEDs, halogen bulbs with filter and laser. Then laser, among laser, the most common is like argon laser and it is having an intensity of 250 megawatt with a combination of plus or minus 50 watt for 10 seconds and it is also done in increments. Next question. All of the following are true about polymerization shrinkage of composite except. So we know that composite, what we need to know what is polymerization shrinkage. Actually, there is a reduction in the amount of composite or there is shrinkage of the composite once we do a curing. And this is called as polymerization shrinkage once seen after the polymerization reaction. So the first option, which is following are true about polymer except. So something is actually wrong among the topics. So which is a wrong? The first is like the more surface area of bonded structure causes less shrinkage compared to surface area of unbonded surface structure. B. Class 5 composite restoration causes contraction more than gold restoration. C. Etching and priming reduce shrinkage. D. One-third of the enamel involved cause more shrinkage. C. Actually, etching and priming actually reduces shrinkage. That is an added method to reduce shrinkage. One. Second, 1/3 of the enamel involved causes more shrinkage. Yes, enamel involvement actually causes shrinkage. Third, class 5 composite restoration causes contraction more than gold. Of course, class 5 actually causes more of a contraction. See the first point. More surface area of a bonded structure causes less shrinkage. No. More the surface area of a bonded structure will more the shrinkage. So it is directly proportional. More the surface area of a bonded structure means more will be the shrinkage when compared to the surface of unbounded structure. So we know that configuration factor that we have to know here. It is actually the division of bonded surface to unbounded surface. Higher the C factor, the greater is the bond being disruption from the polymerization effect. And for a class 1, it is very high of 5. Class 2, it is 2. Class 4, it is of low risk. So please keep this important points in your mind. Next question, which among the following will not reduce polymerization shrinkage? So we know that polymerization shrinkage, as I told, it is actually shrinkage of the composite taking place. So we have to give the composite an increment, and if we give some stress bearing liners in between it to also reduce the shrinkage. Soft start polymerization means the intensity of the curing light is being controlled. High intensity light curing is the first thing that cannot reduce pollen, because high intensity light cure, everything we have to give in an increment so that the stress developed during polymerization is reduced. To reduce that, we have to give either an increment technique. We know that there are a lot of increment techniques like horizontal layering technique, vertical layering technique, etc., etc. So that the amount of stress developed, it is dissipated, then we are applying each layers. Whenever tooth structure is cut with a burr, residual organic and inorganic component form the. So whenever there is a combination of inorganic and organic component with the tooth structure, that is actually a smear layer. So what is Bebley layer? Hybrid layer, we know it is a combination of the composite being engaged into the exposed collagens. Bebley layer is actually a disorganized molecular surface layer that is actually seen in a highly polished metal. Okay, they actually produced by a series of abrasives when we use it has been seen on the surface of a highly polished metal. The other two actually seen on the tooth. When the concentration of the etchant is more than 50%, it forms a complex which prevent further dissolution. The complexes. So there are two important things that is actually formed. If the concentration is more than 40%, if it is less also, if it is more than 40%, it forms mono calcium phosphomonohydrate. If it is less than 27%, it actually forms dicalcium phosphate dihydrate. So the answer for this question, since it is more than 50%, it should be monocalcium phosphomonohydrate. So we know that when we etch, there are micro tags and macro tags being formed. And the most micro tags are having a length of actually 2 to 5 in length. And another important point is like currently the length of application of etchant is 15 seconds. So this important points also you have to keep in mind. Another important point is fluoridated teeth and primary teeth require large amount of time or longer time when compared to the normal etching. That is mainly because of the prismatic enamel that is present. And as we told, the normal etching it is 15 seconds. Here it is actually increased to 20 seconds. After etching, the surface area is increased to 2000 times the original untreated surface. So that is why we actually etch the surface to increase the surface area. And other than phosphoric acid, we use malic acid, citric acid, oxalic acid, etc. And what happens if once the etched area get contaminated with saliva? Again, we have to reapply the acid just for 10 seconds. The normal etching, 15 seconds. If it is fluoridated tooth or prismatic enamel and all, it is 20 seconds. If it get contaminated, it is 10 seconds. The component of Fourth generation dentine bonding systems. For that, we have to know the various bonding agents. We know that dentine bondings are difficult in dentine. That is because dentine is actually a combination of inorganic, organic membrane, and they consist of large amount of dentinal tubule and dentinal fluids, and there's smear layer. All this make dentine bonding difficult. Now, what is a conditioner? Conditioner is always a weak acid. Please think, we use etchant and we use conditioner. Conditioner is actually a weak acid. The etchant we use are actually very concentrated acids like 37% phosphoric acid. Conditioner is like EDTA, that is only for removing the smear layer. But in the case of etching, we do why it actually causes surface increase in the surface area and surface irregularities are formed. So that is the difference. Conditioner, mild acids. Etchant, strong acids. Primer means we know the composite is actually hydrophobic in nature, like it hates water. But our tooth is what? Hydrophilic, because it contains water. So these are two opposite charactered people which are coming together. So in between there should be a person who hold the tooth and hold the composite together. That is primer. So primer is a bifunctional monomer. Means I am the primer means I have both the character of hydrophilic and hydrophobic. So hydrophobic part go and attach to the composite. Hydrophilic part go and attach to the dentine. Right. So first generation dentine bonding agent, actually it chelates with the calcium in the dentine. That was the problem with the earliest dentine where the bond strength was very less, that is 2 to 3 MPa. The second generation, again, it actually reacted with the smear layer calcium. Again, this bond strength was very less. Third generation, they started to modify the smear layer with conditioners. There came the conditioners. Fourth generation was the total etch technique where the enamel and dentine was etched for 15 seconds and the smear layer was removed. But in the case of third generation, it was just modified. And here there came the hybrid layer like concept. Fifth generation, there is two bottle system. The first is etchant, second is primer and adhesive. And sixth generation, first is etchant and the primer combination, and bottle two is actually the adhesives. Seventh generation, it is actually all in a bottle. No mixing is actually required in this case. Now you have to know some of the founders of certain important concepts in composite. Acid etching was found by AB. It is like Bunocore. Hybrid layer by Nakabayashi. BIS GMA is by Bowen. That is why BIS GMA is called as Bowen's resin sometimes. Next question. What is the approximate stress caused by the polymerization shrinkage of composite? It produces 15 MPa stress when polymerization shrinkage of composites take place. Which of the following show ring opening polymerization? So actually, in order to reduce the polymerization shrinkage, they brought a newer type of polymerization, that is ring opening polymerization, that is given by Silorales. UDMA, TechDMA, CDMA, is everything that we use commonly. It have a normal polymerization like initiation, propagation, termination. But this, it is having a ring opening polymerization. So what happens is like the polymerization shrinkage is less. Next concept is soft start polymerization or slow polymerization. Actually, this is seen again brought in order to reduce the polymerization shrinkage that was given by quartz tungsten halogen light cure units. So soft start is actually advocated to reduce the polymerization shrinkage. So what we do is like we will take a low intensity light initially, that is 400 watt, followed by 800 watt. The 400 watt for 10 seconds, followed by we increase the intensity for 800 watt. What is the purpose of acid etching? As I told, etching actually increases the surface irregularity. So the answer is this. But sometimes the option might be like, it might be to reduce the smear layer also. So this both are answer for this question. If somebody asks what is the use of a conditioner, the answer is to, it is a mild acid that remove the smear layer. While working with dental material, the factor C is associated with. Factor C means configuration factors. It is associated with polymerization shrinkage. So the last slide, you need to know certain bond strength. So amalgam bonding agent have a strength of 2 to 6 megapascal. Enamel bonding have 18 to 22. Dentine bonding have 22 to 33. That is highest. So please keep this in mind. Again, ask question. So that is the end of today's class. We had a discussion of the main important point of amalgam, gold, ceramics, and some of a composite actually, and indeed bonding agent in there. So hope you had a nice discussion period. So any doubt, please come to the Idendo section and ask the doubts. Thank you. Keep reading and crack your exam.